surgery because urinary tract infection is not a pure surgery topic. UTI, urinary tract infection. Can you tell me what is the most common organism causing urinary tract infection? Most common organism. So the most common organism causing urinary tract infection is E. coli. E. coli is the most common organism causing urinary tract infection. And to say whether the patient is having UTI or not, we have a criteria known as cause criteria. So Bailey does not mention the name of cause, but Bailey mentions what is the point in cause criteria is mentioned. Just remember the name cause criteria. So cause criteria says a patient is having urinary tract infection in men when there is more than 10 to the power 5 colony forming units. So when there is 10 to the power 5 colony forming units per ml of urine, it is said to be UTI. So what is cause criteria means? In midstream sample of urine. So please remember this is a midstream sample of urine. When there is 10 to the power 5 colony forming units per ml, it is said to be urinary tract infection. In females, we cannot take a midstream urine of sample. So what do you do? We will catheterize them. And we take urine from the catheterized urine is taken out. When it is more than 10 to the power 3 colony forming units per ml, it is said to be positive. So when you have a catheter, the number of units is 10 to the power 3. In men, midstream sample of urine is 10 to the power 5. So anyhow, the most common organism in women as well as in oral, it is E. coli. And in men, the most important infection you should know is most common cause of prostatitis. One of the worst infection in men, prostatitis is also E. coli. So otherwise, there is nothing to be discussed on bacterial infections, especially with E. coli and other infections. There is nothing much to discuss. So let me go to discussion on renal tuberculosis. So this is more important topic in infection. So renal tuberculosis, let us discuss in depth. So renal tuberculosis most commonly affects kidney. It affects kidney. It can also affect ureter. It can also affect bladder. So mycobacterium tuberculosis most commonly spreads to the urinary system by means of hematogenous route. The route of entry is by hematogenous route. It enters to the kidney, ureter and bladder, and from there the urinary tract gets affected by TB. And what is the earliest feature? Earliest and most common feature of renal TB. Answer is, what is the earliest and most common feature of renal TB is increased frequency of urine. So very interesting. You see, when a young male or a female comes to you at around 30 years with increased frequency of urine, what are the differential diagnoses you have? What are the differential diagnoses? Means the differential diagnosis we have will be, it can be either a diabetes, it can be urinary tract infection, or it can be TB. So in a young male coming to you with the increased frequency of urine, you should rule out whether they are having diabetes. We will rule out whether they are having UTI by cause criteria, and we will finally look for TB. In TB, on examination of the urine, what finding you see? On examination of the urine, what finding is seen? 100 times asked MCQ. That is sterile pyuria. Sterile pyuria is seen in renal TB. Sterile pyuria means what? That is, bacteria is absent in the urine, whereas WBC count is increased. So increased WBC count is there, bacteria is absent. This is known as sterile pyuria. Sterile pyuria means bacteria is absent and WBC count is increased. This is known as sterile pyuria. Please remember sterile pyuria. So when a patient comes to you with increased frequency of urine, when we are examining the urine and urine shows sterile pyuria, immediately we advise them to undergo early morning urine specimen test for what? Early morning urine specimen will be done for 3 days. For what? For AFB. Acid phosphacylate. 3 days we have to do early morning urine specimen. So these are the various investigations to find out whether there is tuberculosis in the renal system. And here one important point is there. What is the earliest feature in the kidney? I told you TB commonly affects kidney. What is the earliest feature in kidney? When you examine the kidney will have, for example, if this is kidney, the kidney will have blunting of calyx like this. The calyx will be looking like this. No, it will become blunt like this. So blunting of calyx is the classical feature. Blunting of calyx. So please don't forget the earliest feature of TB is blunting of calyx. Blunting of calyx. And the investigation of choice to diagnose the earliest feature. Investigation of choice to diagnose early TB. I'm not asking advanced TB. Early TB answer was, old answer is IVP. Intravenous pyelogram was the old answer. New answer is CT pyelogram. CT pyelogram is the latest answer to diagnose early TB. So old answer was IVP. Now new answer is CT pyelogram. CT pyelogram is the latest investigation to diagnose earliest change in TB, that is blunting of calyx. Blunting of calyx. So what are the complications of chronic TB? What are the complications? Having a chronic TB. So if the patient is having acute TB, will have fever or even some malaise, tiredness, all those things are seen. Chronic TB patients are very rare nowadays. If at all they come to you with a presentation of cement or putty kidney. Cement or putty kidney is seen. Number one, cement or putty kidney. Then what else is seen? Cement kidney or putty kidney or golf hole ureter. Golf hole ureter. So the ureter becomes like this. So the ureter from the kidney, it becomes like a golf hole. It becomes bent. And the bladder becomes thimble bladder. Thimble small bladder. So thimble small bladder. So chronic TB manifestations are cement or putty kidney, golf hole ureter, thimble or small bladder are the features of chronic TB. So what should I do for these cases of chronic TB? What should I do? So if it is a chronic TB causing multiple complications like urinary tract obstruction and other problems, we have to operate. So acute TB can be treated with ATT, but chronic TB patients will have multiple other comorbid features. Hydronephrosis, patient may have a secondary urinary tract infection, everything will happen. So a patient with cement kidney, golf hole ureter, thimble bladder, all these patients, optimum time of surgery is 6 to 12 weeks. So 6 to 12 weeks after starting ATT. So otherwise, under cover of ATT, we operate at 6 to 12 weeks. So please don't forget these points about renal TB. So these are, so though not high yield as a whole, certain MCQ points are fully asked in exam. So like a thimble bladder, golf hole ureter, and patients who are presenting with sterile pyuria, early morning specimen for 3 days, earliest feature is blunting of calyx. All these are repeat MCQs. Okay, please don't forget these points. So next important topic in this is on trauma. Trauma to the urinary system. So very, very important topic from urology. Trauma to the urinary system. So though we have discussed a few points in trauma chapter, here I'm going to discuss in depth about all trauma individually. So let us first start our discussion on renal trauma. Okay, we are going to start our discussion on renal trauma. So renal trauma, kidney trauma, what is the most common mechanism? The most common mechanism is blunt injury of the kidney. Blunt injury is the most common mechanism of injury to the kidney. Blunt injury, number one. And most common clinical feature is hematuria. So the significant or ominous sign in a trauma patient, the ominous sign, this question is already discussed in trauma itself. Ominous sign to look for kidney injury in a blunt injury abdomen is hematuria. And what is the investigation of choice? Investigation of choice is CECT abdomen. So please don't forget this MCQs. Renal trauma most commonly due to blunt trauma, and ominous sign is hematuria, and investigation of choice is CT abdomen. So recently in AIMS exam they asked renal trauma sequence arrangement of grade. So this is the first time AIMS has asked sequential arrangement of renal trauma question in last AIMS. So I'm going to discuss now the grades of renal trauma. Usually in my classes, I never discuss grades of renal trauma. Since it has been asked in exam, now no other way we have to discuss. So grades of renal trauma I'm going to discuss now. So let us assume this is renal vein, this is renal artery, and now see, this is the capsule. The green color I'm drawing is the Gerotas fascia, and this is a renal capsule. This is renal capsule. This is a renal capsule. So now, if there is a hematoma, very small hematoma, subcapsular, please understand it is nothing to mug up. So it is grade 1 is subcapsular hematoma. So subcapsular hematoma is a hematoma which is seen in grade 1. It is a perirenal or subcapsular hematoma, subcapsular, and it is non-expanding. It is not expanding. So please remember, it is non-expanding subcapsular hematoma, grade 1. So grade 2 is a condition in which there is laceration. There is laceration in the kidney like this. How many centimeters? Less than 1 centimeter laceration. Okay. So and there is hematoma which is confined within the Gerotas fascia. So that is very interesting. So always hematoma will come. Please don't forget. Hematoma, in previously it is confined to capsule. Within capsule. Now it is hematoma confined to Gerotas fascia. So the hematoma is now confined to Gerotas fascia, and the laceration is less than 1 centimeter laceration. So this is known as grade 2 injury. So please understand, very simple. Grade 1 is subcapsular hematoma. Grade 2 is laceration less than 1 centimeter. Hematoma confined to Gerotas fascia. Okay. And grade 3 is whenever there is laceration more than 1 centimeter. So grade 3 is laceration which is more than 1 centimeter laceration. So when you think if there is a laceration huge amount, we will think that urine may extravasate. But here there is no urine extravasation. So no urine extravasation in grade 3. So please remember, grade 1 is subcapsular hematoma, grade 2 is less than 1 centimeter laceration, grade 3 is more than 1 centimeter laceration with no urine extravasation, and then automatically you understand what will be grade 4. So grade 4 will be, the laceration will be seen more than 1 centimeter with urine extravasation is grade 4. Grade 4 is urine extravasation is present. So there is a severe injury, the urine is extravasating outside. So urine extravasation is present. Also there is injury to the renal artery and renal vein. Here also there is laceration. Injury to renal artery and renal vein. Renal artery and renal vein is also there. Main artery, these are main vessel injury. So main vessel is also injured. Probably there is some bleeding going on now in grade 4. So grade 4. So grade 1 is subcapsular hematoma. Grade 2 is hematoma with laceration. Hematoma limited to Gerotas. So grade 3 is more than 1 centimeter laceration, no urine extravasation. Grade 4 is urine extravasation present. This is asked in exam. Urine extravasation is present in grade 4. Grade 4 there is urine extravasation. Subcapsular hematoma is grade 1. So the sequence was subcapsular hematoma followed by urine extravasation followed by grade 5 was given in the exam. So what is grade 5? Shattered kidney. Shattered kidney was there. Shattered kidney. Okay, shattered kidney. Avulsion of renal hilum. Okay, avulsion of renal hilum. So avulsion of renal hilum means what happens? So there will be hilum is totally cut. This hilum is totally cut with uretropelvic avulsion. Uretropelvic avulsion present. So uretropelvic avulsion, avulsion of renal hilum, shattered kidney, complete laceration of main renal artery and renal vein. Complete laceration of renal artery and renal vein. So completely it is cut. Previously it was mild cut. So please remember, it is main vessel is injured but not complete laceration. Here it is complete laceration. So grade 5 is shattered kidney, avulsion of renal hilum, uretropelvic avulsion, complete laceration of renal artery and renal vein. So these are the grades of kidney injury. So this question was asked in AIMS November 2019 as a sequence order arrangement question. So this is the same sequence order. So the question was having subcutaneous hematoma, urine extravasation, followed by shattered kidney, followed by uretropelvic avulsion. Ureter and renal pelvis are torn away, totally disturbed, and complete laceration of renal artery and renal vein. So these are the 5 grades of renal injury. Please don't forget the 5 grades of renal injury. Please make it thorough from your workbook. Repeatedly keep reading the grades. So now, investigation of choice. I just now told you the investigation of choice is CECT abdomen. CECT abdomen is the investigation of choice. If patient is stable, okay, please understand, if patient is stable, CECT abdomen. If unstable, we have to do laparotomy. So if patient is unstable, we will directly go for laparotomy, and in laparotomy, if there is a bleeding from the kidney source only, if patient is unstable, we may even need to do nephrectomy. If there is a huge bleeding coming from the renal artery area, from renal vein area, and patient is unstable, we have to do only nephrectomy. But interesting point here is, since kidney is a retroperitoneal organ fixed in a closed compartment, 90% of them will need no surgery at all. 90% can be managed conservatively without operation. 90% of them are operated conservatively without surgery. Only 10% of them will need surgery. 10% need surgery. Okay. Hence, there is a protocol now I'm going to draw. Patient comes to you, renal trauma patient comes to you. On CT scan, he is stable. So you are taking CT abdomen and you are seeing renal injury present. So when there is renal injury present and patient is stable, what is the investigation that must be confirmed done? You must do this investigation. This is MCQ. Patient is stable, CT scan shows renal injury. What investigation is a must now to look for function of the kidney? The answer is IVP is must. In all stable patients, IVP is must. So if IVP is also normal, we can discharge the patient. IVP is normal, discharge the patient. So that is one AIMS question, old AIMS question. When we are doing IVP for a patient, now let us assume this is the IVP contrast given to the patient that is going and showing the left kidney fully. And it is also excreting to the ureter. But right kidney not visualized. What is the finding? What is the reason? On a stable patient, right kidney not visualized. Left kidney looks normal on an IVP. Why, what happened? What may be the problem? The problem may be there is a hematoma in the perirenal area which is compressing the renal artery, and renal vein compression may be present by a huge hematoma. Therefore, what we must do immediately, this question is a question. On an IVP, left kidney looks normal, right kidney not visualized. The reason is renal artery or renal vein is compressed. Immediately, or the blood supply to the kidney is compromised. So immediately we have to explore the renal hilum. Immediately explore renal hilum. So explore renal hilum immediately. Immediately explore the renal hilum. Please don't forget this. Immediately explore the renal hilum and see for what is actually happening there. See whether the kidney is viable or kidney is gone. If kidney is gone, nothing can be done. We have to remove the kidney. But if the kidney is still viable, usually the kidney will be viable for more than 6 hours. So therefore, if the kidney is still viable, we can repair the renal artery and do a on-table IVP. On table, immediately you do IVP and see whether the kidney is getting good perfusion and urine is coming out. So repair of renal artery should be done immediately. Please don't forget this question. This is an essential question for your exams. In a stable patient, always IVP must be done. If IVP is normal, nothing to worry, send him home. If right kidney is not visualized on IVP, there is some perirenal hematoma. Immediately you must explore the renal hilum. Please don't forget this point. This point you should not forget. Okay. Now coming to the injury of bladder. So we have finished injury to kidney. Now coming to the injury of ureter. Okay. Injury of ureter usually happens during when? When does it happen? Injury to ureter is usually happening during surgery. Injury to ureter usually happens during surgery. By surgeons, gynecologists or some surgeons while operating, accidentally they injure the ureter. So ureter is identified during surgery by what mechanism? So while operating retroperitoneal area, we can identify this is ureter by one mechanism. What is that mechanism? Surgeon identifies the ureter by looking for its what phenomenon? Peristalsis. Please don't forget this one-liner. Ureter is identified during surgery by its peristalsis. And if ureteric injury is identified on table you have identified the ureteric injury. Immediately you must repair it end to end by using what suture material? By using 30 Vicryl we must immediately repair it. On table itself, call the urologist. They will come and repair the ureter. For example, this is ureter cut like this. If it is very nearby that it is easily approximable, you can approximate it and suture it by 30 Vicryl by keeping a stent inside. We must keep a stent inside. So while approximating itself, we will keep a stent inside for healing purpose. So if diagnosed on table itself, repair it by 30 Vicryl, keeping a stent. So please don't forget, repair it on table by keeping a stent, number one. And by chance, if the kidney and ureter are here and you are unable to approximate the lower ureter, it is very far away. This much of ureter is being removed. What are the options? The options are number one, we can create a flap with a bladder like this. We can create a flap with a bladder wall like this and approximate with the proximal ureter. This flap is known as what? What is the name of this flap? This is known as Boris flap operation. This is a one-liner. Boris flap is done for ureteric injury which is unable to be approximated. Boris flap is done for ureteric injury. So Boris flap is derived from bladder. Ureteric injury, we do this Boris flap. Another option for this type of cases is, so this is the bladder, and if the ureter has been totally gone and this is the remaining ureter there, what we do is we bring down this kidney down like this and we approximate the ureter like this now. So this is known as ureteric autotransplantation. So the kidney present in the loin will be taken and kept in the pelvis. See, major procedure for a ureteric injury. Autotransplant of kidney and ureter is done. Kidney and ureter is another option. This is first done by Hardy, old MCQ. It's old MCQ. First done by a person known as Hardy. For ureteric injury in which the kidney and ureter are lying higher up, we remove the kidney and ureter and keep it in the pelvis and do auto-transplant. Everything we have to do. We have to do artery anastomosis, we have to do vein anastomosis, everything we have to do. So everything has to be done after auto-transplantation of kidney and ureter. So this is first done by Hardy. So what are the treatment of ureteric injury means? So please prevent ureteric injury by looking for peristalsis. If identified during surgery, please do a end-to-end suture by using 30 Vicryl, or do a Bori flap operation if it is not accessible, or do a auto-transplant of kidney and ureter from loin to pelvis. So these are the multiple options to manage ureteric injury. So we are discussing a chapter on trauma. We finished kidney, we finished ureter. Now coming to bladder. So bladder injuries. Now we are coming to the bladder injuries. So very interesting point you must know here is bladder is not fully extraperitoneal and not fully intraperitoneal. So this is bladder means this is a peritoneal sac. So part of the bladder is intraperitoneal, part is extraperitoneal. So we can therefore get two types of injuries to bladder. It can be intraperitoneal injury or extraperitoneal rupture. So intraperitoneal rupture of bladder, extraperitoneal rupture of bladder are the two mechanisms. So very interesting topic, full of MCQs. Please listen carefully. So intraperitoneal rupture of bladder, the urine will extravasate into the peritoneal cavity like this. In extraperitoneal rupture of bladder, the urine will extravasate subcutaneous plane into the subcutaneous plane. It will extend, the urine will extend up to the nipple level above. Subcutaneous plane up to nipple level above and up to Holden's line below. Holden line to nipple, between Holden line to nipple, you will have urine extravasated like this. So this is extraperitoneal rupture of bladder. So which is more dangerous? Can you tell me from this itself? So intraperitoneal rupture of bladder is more dangerous because it will cause uremic peritonitis. So therefore, I need to operate. Immediate surgery is needed for these patients. So intraperitoneal rupture of bladder, immediate surgery needed for these cases because they develop uremic peritonitis. Immediate surgery needed. Extraperitoneal rupture of bladder, no emergency. It can be managed gradually. It's not an emergency. It can be managed gradually. So what is the mechanism? That is the only question asked in bladder rupture. So most common mechanism of intraperitoneal rupture is direct blow to a full bladder. A person waking up in the early morning coming with a full bladder, somebody kicks him on the bladder. Direct blow to the bladder. So direct blow causes rupture at the level of dome of bladder. So rupture usually happens in the dome of bladder and results in uremic peritonitis. Extraperitoneal rupture of bladder is due to fracture pelvis. It is usually due to fracture of pelvis. So fracture pelvis causes extraperitoneal rupture of bladder and the urine will be extravasated subcutaneously in the thigh to nipple level. We have urine subcutaneously. It is a superficial extravasation of urine. This we call as superficial extravasation of urine. Superficial extravasation of urine is seen in extraperitoneal rupture of bladder. So now, what is the investigation of choice for these two cases? Investigation of choice for these two cases, especially In case of intraperitoneal, extraperitoneal, whatever it may be, the investigation of choice is we have to do put a catheter and push contrast. So retrograde cystography. Immediately we should put a Foley's catheter and push a contrast. Immediately put a Foley's catheter and push a contrast. Okay. So retrograde cystography is done. Investigation of choices. Retrograde cystography. I will show you the image. Okay. Cystography is done to look for bladder injury. When you put the contour, you where the urine is extravasating, whether it is extravasating outside or into the peritoneal cavity, you can see with this investigation. And treatment of these cases is intraperitoneal rupture of bladder. Immediate repair is done. Immediate repair. Repair immediately. Open the abdomen. Repair immediately. Extraperitoneal rupture of bladder. What we do? Extraperitoneal rupture of bladder. We can wait and watch. Usually it will heal by itself. No need to do surgery. So intraperitoneal rupture needs immediate repair, and extraperitoneal rupture we can wait and watch. It may heal by itself. So please don't forget this point. So what will be the treatment of bladder injuries? So this is a bladder injury points for your exam. So bladder injury points, please don't forget. Now coming to the most important part in trauma, that is urethral injuries. Urethral injuries. This is the most important in your exams. Urethral injury. Male urethra only we are going to discuss. Female urethra we are not discussing here. So male urethra I am going to discuss. So this is bladder, and this is the 20 centimeter of urethra. I am now going to divide the urethra into following. So this is prostate. So the urethra corresponding to prostate is known as prostatic urethra. So this is prostatic urethra. So I am writing as P, prostatic urethra. Then comes the most important urethra, membranous urethra. This is light green I am putting as membranous urethra. What is the MCQ? Anatomy MCQ from membranous urethra. So the least dilatable part, anatomy MCQ, least dilatable part of urethra is membranous urethra. Then comes bulbar urethra. This is bulbar urethra. This is bulbar urethra. Then comes penile urethra. Then comes the penile urethra. So penile urethra. So these are the 4 parts of urethra. I will tell you the MCQs from urethra. Most dilatable urethra is prostatic urethra. Most dilatable part of urethra is prostatic. Least dilatable urethra is membranous urethra. And most narrowest part of urethra is the external urethral meatus is the narrowest part of urethra. So male urethra is 20 centimeter length, 20 centimeter in length. So what are the urethras which can be injured? So now let me see membranous urethral injury. So membranous urethra and prostatic urethra are otherwise known as posterior urethra. Posterior urethra. Penile and bulbar are otherwise known as anterior urethra. So in posterior urethra, membranous urethra is most commonly injured. By what mechanism? Membranous urethral injury is most common, and the mechanism of injury is same like bladder injury. It is fracture pelvis. So fracture pelvis can cause bladder, extraperitoneal rupture of bladder as well as membranous urethral injury. Both can be seen. And in membranous urethral injury, the clinical feature will be blood at urethral meatus. There will be blood at urethral meatus. There will be blood at urethral meatus seen. And the bladder will be full because the urine cannot come out because there is an obstruction of the urine outflow. So therefore, bladder full bladder with the blood at urethral meatus, a patient coming to you. Full bladder and blood at urethral meatus, if a patient comes to you, think of urethral injuries. And important clinical feature here is when you do rectal examination, when I do rectal examination with my finger like this, usually I can touch it. If this is a prostate, I can easily touch the prostate. By rectal examination, I can easily touch the prostate anteriorly. Okay, I can touch the prostate anteriorly on a PR examination. But in this case, the important clinical feature is the prostate will be high lying and floating. Prostate is high lying and floating prostate. High lying or floating prostate is seen. So prostate will be high lying and floating. High lying and floating prostate is seen in these cases. Okay, so please don't forget prostate is high lying and floating prostate is seen in membranous urethral injury. And this sign is what we used to call as Vermeulen sign. It is contraindicated latest guideline. So this sign known as Vermeulen sign is contraindicated now. It is not advised now. We should not do Vermeulen sign hereafter. It is contraindicated. So please don't forget the points I want you to remember are membranous urethral injuries again due to fracture pelvis. It is characterized by blood at urethral meatus, full bladder, high lying prostate, and the urine will be deep extravasation. Please understand the point. In bladder rupture, it is superficial extravasation. Here it is deep extravasation of urine. There will be deep extravasation. Deep extravasation present. There will be deep extravasation present, and the bladder will be going for this shape due to this hematoma. Membranous urethral injury causes this hematoma, compressing the bladder on both sides, resulting in a bladder appearance. What is the shape of this bladder known as? It looks like a inverted teardrop bladder. Please don't forget it is inverted teardrop bladder. It is known as inverted teardrop bladder. Please don't forget this point. The bladder shape is known as inverted teardrop bladder will be seen. So membranous urethral injury, this much of MCQs are there. Still there are more. Please remember these points. So now coming to the other injury. Which other urethra is injured is bulbar urethra is injured. Bulbar urethra is injured. Most common mechanism of bulbar urethral injury is very classical MCQ. The history itself is enough to say this is bulbar urethral injury. That injury is known as straddle injuries. Straddle injuries. A patient walking and putting one leg into manhole, that manhole hits his groin. A person driving a bicycle, the cycle chain goes, he falls on the handlebar. That is known as straddle injuries. So that causes injury of bulbar urethra. That is again characterized by the same clinical features. Blood at urethral meatus and what else? Full bladder. Both features are seen. But here there is no floating prostate. So blood at urethral meatus and full bladder are the features of bulbar urethral injury. So what I'm going to do now for this case, for these two cases, both of them are having full bladder. They are unable to pass urine because of disruption of the urethra. So what I should not do and what I should do. Don't do what? Do what? Don't put Foley's catheter. Don't put Foley's catheter. What I should do? I should put a suprapubic catheter. This is a very classical MCQ. So do and don'ts. So Foley's catheter must not be put in a urethral injury. Suprapubic catheter must be put in a urethral injury. So now see, this is a urethral injury now. This is a urethral injury here. So I have put a SPC and I am draining the urine outside through an SPC. This is going on. So now I want to diagnose where is the urethral injury. There are two methods. So please understand this question came in recent NEET exam as an image-based question. The two questions are, I can put a Foley's catheter up to the tip of penis. So please remember, I can put a Foley's catheter up to tip of penis. I'm not going inside. Up to only penile tip, I'm putting a Foley's catheter. And now I can push the contrast. See, I'm pushing the contrast. I will push the contrast like this back to the bladder like this. If I push a contrast like this and look for urethral injury or leak, what is this investigation known as? This is known as retrograde ureterogram, RGU. So in case of urethral injury, I can do retrograde ureterogram, one investigation. Or else I will fill from above. I have already an SPC, so I can fill from above. I can fill the entire bladder from above through the SPC and ask the patient to pass urine. Ask him, fill the bladder and ask him to pass urine now. Now you pass the urine. We ask him to pass the urine. It will come like this. This is known as, what is it? Micturating cystogram, cystourethrogram, MCU, also known as descending urethrogram. Both are same. Descending cystourethrogram. So both can be done for a trauma patient of urethra. So what are the investigations of choice for urethral injuries means I can either do a retrograde uretrogram or I can do a micturating cystourethrogram. How to differentiate whether it is MCU from the image or RGU from the image? First point is, if the contrast is flowing through the Foley's catheter, it is RGU. If the contrast is flowing through the SPC, it is MCU. First point. And in MCU, you can see bladder is full. Bladder is full with the contrast. In RGU, bladder will be incomplete. I will show you the image. You will understand it. In both cases, we don't do anything now. We wait for how many weeks? We wait for 6 to 8 weeks. Nothing is done. We put an SPC and send them home for 6 to 8 weeks. After 6 to 8 weeks, usually these patients present to you with what complication? The place where the urethra is injured, that will go for benign urethral stricture. Will result in urethral stricture. If it is a short, small stricture, we can dilate with the dilators are available. Dilators are available for small and short strictures. If the stricture is multiple and long stricture, we cannot do dilatation. Such patients, we will do surgery. What surgery is done? The surgery is known as stricturoplasty. Stricturoplasty will be done. We open that stricturous area. We reconstruct the urethra by using a what flap? Buccal mucosal flap will be used. Buccal mucosal flap will be used. So the buccal mucosa will be now forming the urethra. So urethral stricture, we allow them to form a urethral stricture in 6 to 8 weeks. And once stricture is formed, we have dilators through which we will dilate it. If it is a short stricture, if stricture is long and big, we have to use buccal mucosal flap for these patients. So these are the important points in trauma: renal, ureter, bladder, urethral traumas. So please don't forget. Let me show you the images now. So what is cause criteria? Presence of more than 10 to the power 5 colony forming units in a mixed in urine, or 10 to the power 3 in a normal patient with catheter. You can note here the gold fold ureter, image based question. Gold fold ureter, you can note it here. This is a gold fold ureter. This is blunting of calyx. You can see the cement kidney or putty kidney seen on X-ray itself. And here you are seeing a very small filled structure, that is thimble bladder. Thimble bladder you are seeing. So I got the pictures from various internet sources. So nowadays these cases are very rare. Thimble bladder, putty kidney, and gold fold ureter. All these are findings of chronic TB. And investigation of choice now is CT urography or CT pyelography. The optimum time of treatment is 6 to 12 weeks from Bayesian law. Okay, after starting ATT, 6 to 12 weeks. So urinary tract trauma, please don't forget the grades of laceration. Can you tell me in which grade of laceration urine extravasation seen? In which grade of this laceration? 1, 2, 3, 4, 5. Who will have urine extravasation? Grade 4 will have urine extravasation. Among this grade, which grade will have injury of main renal artery and main renal vein? Injury of renal artery and renal vein is present, but it is not a full transection. In grade 5, it is a full transection. Grade 5 is shattered kidney, disconnection between vessels, disconnection between ureter and renal pelvis. Everything is seen in grade 5. So please don't forget. Grade 1 is subcapsular hematoma. Grade 2 is hematoma within Gerota's fascia. Okay. So surgical exploration is needed in less than 10%. 90% can be managed by conservative methods. This is the picture I'm explaining about intraperitoneal rupture of bladder, extraperitoneal rupture of bladder, membranous urethral injury, and bulbar urethral injury. Now let us see the investigations. See what urethra is injured here. Classical old Bailey picture. This picture is removed in Bailey. Probably in Western countries they started closing the manhole. It seems now there is still manhole present in our country. So we have to remember bulbar urethra is injured in this. Bulbar urethra is injured in straddle injuries. So this is an extraperitoneal rupture of bladder. The urine is extravasating out. Extraperitoneal rupture of bladder on a cystogram. You can see this is a hematoma located here, compressing the bladder, and the bladder is having a inverted tear-shaped appearance. Where will you get this inverted tear bladder? In case of membranous urethral injury. Very good. Membranous urethral injury. So bladder injuries, please don't forget, we have to do retrograde cystogram, or we have to do IV cystogram, intravenous IVP. When you do, we have to wait for the cystogram phase and then we do the leak. So best answer for cystogram is retrograde cystogram. Is the best answer to look for bladder injuries. Otherwise, it is also known as ascending cystogram. Ascending, it is ascending, no? So it is ascending cystogram or retrograde cystogram. So now you see the two pictures of a bulbar urethral stricture. So bulbar urethral stricture 1, bulbar urethral stricture 2, both are same cases. In this picture, if you see, in the first picture, you can see there is contrast pushed from here to here like this. So therefore, the bladder is not fully filled, it is only incompletely filled. So therefore, this investigation is RGU, retrograde urethrogram. On the second case, you can see there is some cannula put inside the bladder. So there is a cannula put inside, the bladder is full and you are asking him to pass urine. As he is passing urine, we are taking the picture that is showing you micturating cystourethrogram. So micturating cystourethrogram, the bladder will be filled. Bladder will be filled and we ask him to pass urine. Retrograde urethrogram, the bladder will not be full. So this is very important investigation. So you can see these are all chronic cases with the strictures. By a retrograde urethrogram, you can see Foley's catheter we are pushing contrast, RGU. So here you can see again another retrograde urethrogram showing you membranous urethral stricture. Membranous urethral stricture. So all these are very various images you may get in exam. So you must not forget these pictures. Okay. So trauma is an important topic. Please don't forget these points in trauma. The next topic we are going to discuss is an interesting topic: congenital anomalies in kidney, ureter, bladder. Congenital anomalies. We are going to discuss now congenital anomalies in kidney, ureter, and bladder. Okay. So before going to the congenital anomalies, let me tell you the various anomalies we are going to discuss in this chapter. Congenital anomalies chapter. So the various points, various topics we are going to discuss in this chapter are, so very important topic, polycystic kidney disease we are going to discuss, PCKD we are going to discuss, ectopic ureter we are going to discuss, congenital pelviureteric junction obstruction we are going to discuss, full of MCQ points, uretrocele we are going to discuss, uretrocele, horseshoe kidney we are going to discuss. So then we are going to discuss vesico-ureteric reflex, VUR we are going to discuss, ectopia vesica we are going to discuss. So in this, the first point I want to tell is, the polycystic kidney disease has no sex prediction. It is equal in male and female. There is no sex prediction. Most of them are common in males. Most of the congenital anomalies of kidney and urinary system is common in males, except the following. ectopic ureter is common in females, most common in females, and urethrocoele is common in females. And BUR, we have two types, congenital and acquired, congenital type and acquired type. So congenital and acquired, we have two types. Acquired type is most common in females. So what are all things which are common in females alone? You remember all others are common in males. Ectopic ureter, ureter problem. Urethrocoele, ureter problem. Vesico-ureteric reflex, another ureter problem. So ureter problems are more common in females. One shortcut method to remember. Ureter problems are most common in females. Okay. So now let us discuss one by one the various anomalies. First, I'm going to discuss about ectopic ureters. Very important topic for your exam, ectopic ureters. So the most common anomaly in kidney is what? Can you tell me what is the most common anomaly in kidney? The most common anomaly is duplication of renal pelvis like this. So there is two renal pelvis, duplication of renal pelvis and ureter. This is the most common anomaly. So duplication of renal pelvis and ureter is the most common anomaly. Duplication of renal pelvis and ureter. Renal pelvis and ureter is the most common. It is usually unilateral, more common than bilateral. It is usually unilateral. Now I'm going to discuss the classical points of ectopic ureter. Now assume this is a normal ureter, normal joining to bladder. Ectopic ureter usually arises from upper pole. Okay, ectopic ureter usually arises from upper pole and run downwards, outwards, laterally, and join distally. Somewhere it joins distally. So the green color one which I have drawn is an ectopic ureter. What are the properties? It arises from more proximal or upper pole. Upper pole ureter is usually abnormal, number one. Number two, it runs lateral, outwards. And where does it join? It joins distal to the normal ureter. So ectopic ureter features are, it is arising from upper pole, it runs laterally, outwards, and distally. So it runs laterally, outwards, and distally. And this is one type of ectopic ureter. Another type of ectopic ureter, let me draw now. Ectopic ureter can present in multiple methods. Another method is this. So in the next method, what happens? The upper pole ureter will get obstructed like this. Somewhere it is obstructed. After that, it is not going down. Okay, upper pole ureter is not going down after that. It is obstructed at one place, and this results in stagnation of the urine like this here. It results in stagnation of the urine in the upper pole, and it results in urethrocoele. It is known as urethrocoele. Inside the urine, inside the upper ureter, which is obstructed, urine gets collected. So upper ectopic ureter gets obstructed. And the normal ureter is not normal. It will develop one more problem, that is vesico-ureteric reflex. So the normal ureter will develop BUR. This is another pathology. So ectopic ureter can present in different ways. The presentation ways are in one condition. The ectopic ureter arises from the upper pole, runs downwards, and joins distal to the normal opening. Somewhere distal to the normal opening. And in men, where does it open? In men, it opens into the prostatic urethra. It opens exactly in prostatic urethra. We should not tell it as men. In boys, it opens in prostatic urethra. In girls, where does it open? It opens in urethra. It opens distal to external urethral sphincter. Very important. External urethral sphincter is the one which controls whether we can pass urine or control urine. Here in girls, it is opening distal to the external urethral sphincter. So what will be the presentation in girls? Girls will have paradoxical urinary incontinence. Girls will have paradoxical urinary incontinence. So there will be continuous dribbling of urine will be seen. There will be dribbling of urine and paradoxical urinary incontinence will be seen in girls. Boys will develop only urinary tract infection. Okay, so there is a rule which is mentioning about this known as Wiegert-Mayer rule. What this rule says? Wiegert-Mayer rule. The rule states the upper pole is usually an ectopic ureter. Upper pole ureter is usually an ectopic ureter, and its orifice inserts. Its orifice is usually seen infiromedial. See, this is a normal orifice, and this is infiromedial to the normal ureteric opening. That is known as Wiegert-Mayer. Upper pole is ectopic, and if it enters, it will enter infiromedial to the normal ureter. So this is Wiegert-Mayer rule. So the infiromedial means this is like that. So this is the normal opening of ureter. This is infiromedial opening. So this is Wiegert-Mayer rule. 100 times asked question. Wiegert-Mayer rule is applied for which condition? Means it is for ectopic ureters. So ectopic ureter, one is opening infiromedial. Another is ectopic ureter getting obstructed, forming an urethrocoele. Another feature is what? Another interesting feature is this. So one ureter is normally entering the bladder, and the ectopic ureter enters into this ureter itself. So what will happen? The urine which will go like this, will reflex back into the kidney like this. This is known as yo-yo reflex. Yo-yo reflex ureter. So yo-yo reflex is also a type of ectopic ureter. Yo-yo reflex is also a type of ectopic ureter. So three pathologies I have told in ectopic ureter. One is joining infiromedially in females causing paradoxical incontinence. Another is the ureter is getting obstructed, forming a urethrocoele. Another is yo-yo reflex. And when you do IVP is diagnostic of ectopic ureter. IVP is diagnostic of ectopic ureter. And in the second picture which I told you, there is a urethrocoele. See, this is a urethrocoele. The upper ureter is obstructed. That is urethrocoele. So what will happen? This urethrocoele will compress the remaining kidney, and the remaining kidney will be like this. Will go like this, and this is a normal ureter. And the renal calyces, these are the normal renal calyces. So that kidney is pushed down, and that appearance on IVP will be like this. On appearance on IVP is, what is this appearance? It is looking like a drooping lily appearance. So please don't forget drooping lily appearance seen. Drooping lily appearance is seen in neuroblastoma also. It is also seen in here, this place also. Drooping lily appearance seen in ectopic ureter with urethrocoele. Ectopic ureter with urethrocoele, there is drooping lily appearance. So please don't forget this point. Drooping lily appearance is seen in ectopic ureter with urethrocoele. Please don't forget this is one IVP appearance. IVP appearance. So please don't forget the lower pole ureter will reflex, upper pole ureter will form a obstruction and cause a drooping lily appearance. So these are the classical MCQ points from ectopic ureter. Now I am going to polycystic kidney. Even in NEET 2020, we had a question from polycystic kidney disease. It is also known as autosomal adult polycystic kidney disease, or there are two types. Adult type is one which we are going to discuss. I am not going to discuss about infantile type. Infantile polycystic kidney disease, it is seen in babies less than 1 year, and it is autosomal recessive. They die in 1 year, so nothing to discuss. So infantile polycystic kidney disease is seen less than 1 year. and they will not even survive for 1 year. Most of them will die, and it is autosomal recessive. What we are going to discuss is adult polycystic kidney disease. It is autosomal dominant disease. It is autosomal dominant disease. So the disease is autosomal dominant. Okay. So please remember, what is the criteria to say adult autosomal dominant polycystic kidney disease? Criteria to diagnose, very important for your exams from Bailey Law. So what are the criteria to diagnose autosomal dominant polycystic kidney disease? Just with ultrasound, nothing else. Just with ultrasound, if one kidney shows 3 cysts. So please remember, one kidney shows 3 cysts, at least 3 cysts. Or if bilateral kidney having cysts, at least 2 in each, 2 cysts in each. So this is said to be polycystic. It is sufficient to diagnose polycystic kidney disease. Polycystic kidney disease is easily diagnosed with ultrasound itself when there is minimum 3 cysts in one kidney and at least 2 cysts in both kidneys. Then it is said to be autosomal dominant polycystic kidney disease. Okay. Now coming to the clinical features. So please remember, polycystic kidney disease is always bilateral. It is always bilateral in 95% cases. It is 95% cases bilateral, and it is seen in 1 in 400 to 1 in 1000 people. It is seen in 1 in 400 to 1 in 1000 people, and this is manifest usually before 40 years. Before 40 years, they come to hospital with a classical clinical feature. What? They come to you with hypertension. Hypertension is the classical presentation. Actually, that hypertension is due to kidney failure. They develop kidney failure from 40 years onwards. Until 40 years, they will be living normal life. By 40 years, what happens? The entire kidney is replaced by cyst, and they develop kidney failure and they develop hypertension. So the kidney will be enlarged. When you palpate itself, you can see the kidney will be enlarged like anything. 3 to 4 times enlarged with full of cyst. The cyst will replace the kidney substance. The cyst will contain fluid. That fluid is not urine. Please remember, that fluid is not urine. The renal tissue is progressively replaced and leads to renal failure. The most common presentation is hypertension, which can be seen from 20 years onwards. From 20 years onwards, the patient can come to you with hypertension. Other rare features. So kidney failure is seen in 40 years onwards. This is the course of these guys. And other rare features are hematuria can happen. Please don't forget, hematuria can happen due to rupture of cyst, or they can present to you with the kidney stones. This question is an expected question. In polycystic kidney disease, what is the most common type of stones? Means it is uric acid stones. It is seen in 20% cases. So very interesting. 20% of the patients presents to you with the uric acid stones more commonly. And end stage renal disease, end stage renal failure is most common in men than female. They will finally land up in end stage renal failure and they will go for dialysis. So the treatment they will be undergoing is dialysis treatment will be gone. So they will go for renal failure. So interesting question. What they ask you is, in polycystic kidney disease, what are the associated anomalies? Associated anomalies is a repeat question. You can also develop cyst in which places? You can develop cyst in liver, spleen. You can develop cyst in liver, spleen, pancreas. You can develop ovary. Where cyst is not seen, even that is also seen, but old MCQ, it is not seen in lungs. So just for MCQ, remember, but nowadays they have also found it in lungs. So cyst is found in liver, spleen, pancreas, ovary. And very, very dangerous problem is they have berry aneurysm, which can suddenly rupture, causing thunderclap, headache, and subarachnoid hemorrhage. Berry aneurysm. Heart, they have mitral valve prolapse syndrome. MVPS in heart. And this question is the question which is asked in exam. A patient with autosomal dominant polycystic kidney disease presents with sudden abdominal pain. The answer is colonic diverticulitis. Colonic diverticulitis is very common in these cases. So colonic diverticulitis is another important thing you should not forget. And they may also develop liver fibrosis. Liver fibrosis. So even though liver is developing, even though the liver is going to develop cyst, please remember, they will not develop liver failure. That is the interesting point. They develop renal failure, but in spite of liver being replaced by cyst, liver failure is not seen. These are the associated anomalies. In this, the question asked in NEET 2020 is sudden abdominal pain in a polycystic kidney disease due to colonic diverticulitis. Sudden headache is berry aneurysm. Okay. Sudden cardiac failure is MVPS. All these things are associated anomalies. Please don't forget. Coming to the treatment. The treatment of polycystic kidney disease, olden days was what? In olden days, they did an operation known as rousing operation, in which they break the cyst one by one. They break the cyst one by one, thinking laparoscopically they will break it, thinking the kidney will function, will recover. But it is no use, not done nowadays, just for completion. And presently, we have some conservative treatments like tolvaptan. Tolvaptan is a new drug which is used. It is a vasopressin. It is a vasopressin receptor antagonist. Please don't forget, this is also asked in NEET 2020. Tolvaptan is a vasopressin receptor antagonist. It is a first approved drug. It is a first approved drug. First approved drug for adult autosomal dominant polycystic kidney disease. They will have increased urine excretion. They will have increased urine excretion, and actually they increase the urine excretion, and therefore they increase the sodium content in the body. So increases sodium content in body. So therefore vasopressin receptor antagonist increases sodium content in the body and excretes more amount of urine. Therefore tolvaptan is not only used for autosomal dominant polycystic kidney disease, it is also used in cirrhosis patients who have hyponatremia, heart failure patients who have hyponatremia. All these cases we use tolvaptan. Autosomal dominant polycystic kidney disease, cirrhosis patients and heart failure patients, all these patients we use tolvaptan. Tolvaptan is used. So please don't forget, tolvaptan is a drug, vasopressin receptor antagonist. What is the treatment of choice finally for these cases? Nothing, just transplant, kidney transplant, that's all. No other option. Until you are going to do a transplant, we can extend their survival by dialysis and tolvaptan. So transplant is the final option for these cases. Okay, final option for these cases is transplant. So next topic is congenital pelviureteric junction obstruction. So congenital pelviureteric junction obstruction, common among males. So the most common cause of congenital hydronephrosis is this. Most common cause of congenital hydronephrosis is congenital pelviureteric junction obstruction. What happens here? We don't know the exact reason. What happens here is there is some obstruction which is non-functional. It is some functional. There is no obstructive lesion there at the level of pelvis and ureter. At this level, there is an obstruction. That is what known as congenital pelviureteric junction obstruction. What is the cause? Cause is unknown. Is it caused by any abnormal arteries running here? Is it caused by any abnormal renal artery or renal vein? No. It is not caused by abnormal renal arteries. Abnormal arteries can be seen. Abnormal renal artery or renal vein may be seen, but it is not the cause. May be seen, but it is not the cause. Aberrant renal vessels is not a cause of congenital pelviureteric junction obstruction. It is most common in boys. most common in boys, and usually unilateral but bilateral in 40% cases also. Up to 40% cases can also develop bilateral. So please don't forget, it is more common in boys, it is unilateral, 40% cases it will be bilateral also. So one test used to differentiate this is, we measure the pressure at the renal pelvis and we measure the pressure at the bladder. We measure the pressure at the renal pelvis and we measure the pressure at the bladder. So that is pressure measurement here and here will be usually same, renal pelvis and bladder will be same, but here the pressure here is high, here it is low. This is to show you there is an obstruction at the pelvic junction, and this test is known as Whittaker test. Whittaker test. So Whittaker test is used to find out the pressure difference in renal pelvis and bladder. So Whittaker test is used in congenital pelvic junction obstruction. Please don't forget, congenital pelvic junction obstruction, we use Whittaker test. And the treatment of this case is very simple. We have to dismantle this area, pelvic junction area, we have to dismantle and do reanastomosis. This is known as Anderson's Heinz pyeloplasty. So this procedure is known as Anderson-Heinz pyeloplasty procedure. So in which we cut the renal pelvis and reanastomose the ureter, known as Anderson-Heinz pyeloplasty procedure. Please don't forget, this anomaly known as congenital pelvic junction anomaly. The next one is vesicoureteric reflex. As I already told you, it is congenital or acquired. Congenital is most common in boys. Acquired is most common in girls. Usually it is common in girls following a recurrent urinary tract infection, they get this. So it is most common in boys congenitally. Acquired is common in girls. And what is the reason for this? What is actually having? It is same like GRD. What happens? The urine from the bladder, when passing out, it reflexes into the ureter like this. It means there is a problem at the vesicoureteric junction. There is a problem here. What problem is there? The problem is there in the longitudinal bladder muscle. Please remember this MCQ. Longitudinal bladder muscle is deficient. So longitudinal bladder muscle deficiency causes reflex, and that's our intramural part of that ureter is also disturbed, and therefore longitudinal muscle deficiency causes reflex. Okay, that reflex is known as vesicoureteric reflex, and there is a classification, international classification system. International classification of vesicoureteric reflex. So very simple. So this is a kidney, this is ureter, bladder. So grade 1 is there is a reflex with non-dilated ureter, reflex into a non-dilated ureter. So reflex into non-dilated ureter, that is answer, grade 1. Non-dilated ureter getting a reflex is grade 1. Grade 2 is the reflex is going back into the, not only ureter, it is going back into the collecting system like this, going up to collecting system, but it is still non-dilated. Non-dilated ureter. Non-dilated, but going to collecting system. The urine is going to collecting system, such a huge reflex going into the collecting system. Grade 3, now grade 3 starts with dilated ureter. Grade 3, the ureter is dilated like this. So there is a dilated ureter, grade 3, dilated ureter seen. The urine is reflexing into a dilated ureter, and there is blunting of calyx seen. Blunting of calyx seen. Okay, dilated ureter with blunting of calyx is grade 3. Grade 4 is a condition in which the ureter is grossly dilated like this. Ureter is grossly dilated like this. Okay, grossly dilated ureter is 4. And 5 is a condition in which the kidney is gone. The kidney is totally damaged. That is, calyces show damage. Gross dilated ureter, renal pelvis, everything is disturbed, injured. So renal injury is present. Renal injury present. Because of gross dilatation and reflex, renal injury is present. This is international classification of vesicoureteric reflex. In this you can see who can you manage without any surgery. Simply you can manage non-dilated ureters with no surgery needed. 1 and 2, no surgery needed. They will develop only UTI. Therefore give them antibiotics. That's enough. We will wait for them to heal. So grade 1 and grade 2, no surgery needed. Who will you operate? Operation is indicated for grade 3 bilateral, grade 4 bilateral, and for renal injury patients, we operate these patients. And for even unilateral, grade 5 operation, operate these cases. So very simple, you must understand this because this is the question, only question asked from this. In a vesicoureteric reflex, what will you do? Medical treatment is enough for grade 1 and grade 2 injuries. Medical treatment is enough for grade 1 and grade 2 injuries. Medical treatment is enough for grade 1 and grade 2 injuries. Grade 3, grade 4, grade 5 injuries, we must operate. Grade 3, especially if it is bilateral, grade 4 bilateral, grade 5 renal injuries, we must operate. And those patients with 1 and 2 not responding to antibiotics also operate. Not responding to antibiotics, grade 1 and 2 also operated. So this is very important thing you must not forget. When to operate a vesicoureteric reflex, the treatment is very simple. Re-implant the ureter. Re-implant ureter is a treatment. So now I want to tell you the investigation of choice for VUR is very simple. To see whether there is a reflex, we should ask the patient to pass the urine. That is micturating cystourethrogram. Investigation of choice to diagnose VUR is micturating cystourethrogram. So now let us see what are the things we have discussed so far. First we discussed ectopic ureter. Ectopic ureter we discussed. Then we discussed autosomal dominant polycystic kidney disease. Then we discussed congenital pelvic junction obstruction. Then the fourth one we have discussed is vesicoureteric reflex. I want to focus more on the investigations. Ectopic ureter investigation is intravenous urography, IVP or intravenous pylography. IV contrast when we can see the ectopic ureter. Autosomal polycystic kidney disease, CTKUB is enough. Congenital pelvic junction obstruction, we use MAC3. Introduction of the chapter I told you, MAC3. Vesicoureteric reflex, micturating cystourethrogram. So these are the 4 topics we have discussed so far. Still we are going to discuss 3 more diseases are there. So please don't forget this 4: ectopic ureter, autosomal dominant, congenital pelvic junction obstruction, VUR. So next I am coming to horseshoe kidney. Horseshoe kidney. So horseshoe kidney is seen in 1 in 1000 and most common in men. Very interesting. 1 in 1000 and most common in men. Usually the kidney is fused at the upper pole or lower pole. It is usually fused at the lower pole. At the level of which vertebra? At the level of L4 vertebra. Please don't forget. At the level of L4 vertebra, the lower pole fusion is common. Lower pole fusion is common at the level of L4 vertebra. Okay, L4 vertebra. So now, the presentation, what presentation these patients may come. The only problem is usually they will be living asymptomatically. I have at least 4 or 5 patients in my clinic itself regularly coming for some other pathologies, but on ultrasound we found a horseshoe kidney. They will be usually asymptomatic, nothing to worry, they will be asymptomatic. The only condition or only place where we cut this Only place where we cut this isthmus is when I'm going to operate a aneurysm. Which aneurysm? Abdominal aortic aneurysm surgery. So abdominal aortic aneurysm surgery, if I'm going to do, at that time only I will cut the isthmus. Otherwise, isthmus cutting is not at all needed. Isthmus cutting is not at all needed for these patients. And what is the IVP appearance? Intravenous pyelogram shows you one classical MCQ. What is it? It is known as flower vase appearance. Flower vase appearance or handshake appearance, like a handshaking each other. Handshake appearance or flower vase appearance is seen on IVP. I will show you that image. And what about females under pregnancy? Can we allow pregnancy? Can we allow pregnancy in these patients? Yes, you can allow. Nothing will happen except there will increase urinary tract infection. So pregnancy is not a contraindication. Please remember, only urinary tract infection is the only complication seen. Okay, therefore pregnancy can be allowed for these patients. Pregnancy is not a contraindication for horseshoe kidney. So please don't forget, they show you flower vase or handshake appearance. The fusion is at the level of L4. The isthmus is cut. The connection is cut only in surgery known as abdominal aortic aneurysm cases. Abdominal aortic aneurysm cases only we cut the isthmus. Please don't forget this point. Okay, so this is very important. Horseshoe kidney 1 in 1000. Next, I'm coming to ectopia vesica. It is a problem in the bladder and anterior abdominal wall. The major problem here is also known as exstrophy or ectopia vesica. The major problem here is the cloacal membrane develops too much and ruptures. So since the cloacal membrane overdevelops and ruptures, there is a huge defect in the anterior abdominal wall like this. There is a huge defect in the anterior abdominal wall like this, and you can see the posterior wall of bladder with its ureteric orifice is seen. Anterior wall is absent. Anterior wall is absent. You can see directly the posterior wall with its ureteric insertion. You can see in ectopia vesica. The major problem is the urine will be flowing out like this. Urine will be flowing out like this. So what are the anomalies associated? That is the only question they will ask you. In males, in females, what are the associated anomalies? In males, the associated anomalies are umbilical hernia, inguinal hernia. In males, there will be umbilical hernia, inguinal hernia, and epispadias and undescended testes. In males, umbilical hernia, inguinal hernia, epispadias, undescended testes. In female, umbilical hernia, epispadias, and split clitoris, and wide opened pelvis. So because of the wide opened pelvis, these girls walk with a waddling duck-like gait. Duck-like waddling gait is seen. Duck gait is seen in these girls, and they will also have wide labia. So please remember, what are the problems associated in females and what are the problems associated in males. The major issue in this is they have total urinary incontinence. They will have urinary incontinence. The continuous dribbling of urine will be seen outside, and they have increased risk of bladder cancer. So exstrophy of bladder or ectopia vesica. Please don't forget, they will have ectopia vesica, will have epispadias associated, and the treatment is plastic reconstruction. Plastic surgeon should come and do reconstruction of the abdominal wall and create a new bladder. Okay, they should come and reconstruct the bladder, new bladder. I will show you the images of reconstruction. So that is ectopia vesica. The last congenital anomaly for upper urinary system is uretrocele. So uretrocele is a condition in which the lower part of ureter becomes dilated like this, and giving an appearance of what appearance on IVP? 100 times asked question. So on IVP, this looks like cobra head appearance. So the major issue in uretrocele is this will cause stagnation of urine and urinary tract infection. So the most common in females, they are most common in females. As I already told you, 10% is bilateral. So they present most commonly with UTI. Ureteric reimplantation is a treatment. Like in BUR, we reimplant the ureter. So don't forget this topic. Reimplantation of ureter is a treatment for uretrocele. So now let me show you the images of these anomalies, full of interesting pictures. You must not forget any picture. So all the anomalies are common in males except ectopic ureter, uretrocele, and congenital and acquired BUR. So these are the three things common in females: acquired BUR, ectopic ureter, and uretrocele. So the most common anomaly is duplicated renal pelvis and upper ureter. You can see the upper ureter is an ectopic ureter going down and joining at the prostatic urethra. Please don't forget, we get Mayer rule. Please don't forget. So the upper pole gets obstructed, results in uretrocele. Lower pole ureter gets VUR. This is one pathology. Another pathology is VUR is yo-yo reflex, reflexing of urine back to the kidney, causing yo-yo reflex. So this is a typical infantile polycystic kidney disease. The babies will die within 1 year. They die in 1 year. So this is an adult polycystic kidney disease. On IVP, you are seeing one classical MCQ appearance. What is this appearance? So this appearance has been asked 1000 times. What is it? Spider leg appearance. So please don't forget, spider leg appearance is seen in IVP of polycystic kidney disease. Okay. So polycystic kidney disease associated anomalies, colonic diverticulitis can cause sudden abdominal pain. This question came in NEET PG 2020. So rousing operation was no more done. The ultimate treatment now is renal transplantation. So please don't forget the drug tolvaptan, vasopressin receptor antagonist. Increases urinary excretion. So this is a congenital pelvic junction obstruction. You can see urine is not coming beyond, and this kidney is dilated or distended. The treatment is we have to investigate with Whittaker test. Pressure difference is present, and these cases will be taken up for Anderson-Heinz pyeloplasty. Anderson-Heinz pyeloplasty is done for these cases. So this is a VUR. You can see a vesico-ureteric reflex grade 3 in the first picture and grade 4 in the second picture. So severe VUR. VUR is due to longitudinal muscle deficiency. 1 and 2 are normal ureters. 3, 4, 5 are dilated ureters. So 1 and 2 you can do medical treatment. 3 and 4 we need surgical treatment. 3, 4, 5 we need surgical treatment. So you can see this is a flower vase appearance seen in horseshoe kidney, and it is at L4 level. They are fused with each other. You can see the classical split pelvis and epispadias. This is a reconstructed bladder you are seeing here. Reconstructed bladder in ectopia vesica. So this is a picture showing you cobra head appearance, like a cobra head appearance seen in uretrocele, clean uretrocele. With a typical cobra head appearance is seen in uretrocele. So this is very classical MCQ topic, congenital anomalies of kidney. So far we have discussed in kidney various topics like renal stones, tumors, infections, trauma, and congenital anomalies. So kidney, ureter, bladder is a high yield topic. Though this is a big chapter, you must thorough all these points. So please thorough all these points. Thank you.